Today we have the privilege of hearing from Dr. Rich Makowiec, Chief Surgical Officer, and Frank Boggio, Chief Development Officer for Synergy Health Partners, who will be presenting on the Surgicalist Model, Staffing and Management Innovations for Rural Health Hospitals. Before we begin, though, I would like to extend our sincere thanks to our dedicated partner, Synergy Health Partners. We are grateful for their continued support and industry expertise, which allows us to host conferences, educational webinars, and other events dedicated to improving rural healthcare. Their support is critical to our mission of advancing rural health initiatives. So without further ado, I'll turn it over to Frank for our feature presentation.
Thanks for joining us today. It's a privilege to be with you. We thought we'd start with a couple polling questions to get things moving as we progress through the presentation. The first question, do you think your local hospital has the surgeons needed to serve your community? There's a yes, no, or I don't know options.
All right, thank you, Frank. I'll leave this open just for a couple seconds to allow everyone to answer. All right, thank you everyone for your participation. I'll go ahead and share those results for you now. It looks like we're at 44% said yes, 44% said no, and 11% said I don't know.
That's actually pretty typical, I would say. As a complement to the prior question, have you heard of the Surgicalist model?
Right, thank you. We'll leave it open just for a couple seconds here to allow everyone some time to vote. Great, thank you so much, everyone. I'll go ahead and share those results now. So it looks like we're at 11% yes and 89% no.
Very, very interesting. And again, that speaks to it being a new service line. It is a rapidly expanding service line for us. We particularly are excited about the rural health market. We're able to work in partnership with those hospitals to increase patient volume and keep people in the communities. Rich, do you have any comment on that?
Yeah, I think, you know, this is the audience we want to be talking to, is rural health, and those numbers give us an idea that we've got a message that should be helpful, hopefully valuable to some of you, and enlighten you on what this model is and how it can be helpful in either yours or other rural communities.
Thank you. So today is especially exciting to me. Much of my background and experience has been in the rural market. My early days were in that market working with critical access hospitals. So our agenda for today are market forces impacting rural hospitals, synergy in the surgicalist model, profile of a surgicalist. We'll look at a case study today, and of course, time for questions and answers. So really what's driving all of this, and may not be a surprise to you, is our population is changing. The paradigm is changing. More and more of us are aging. 10,000 Americans are turning 65 every day. And more of us, including myself in that group, require surgery. Additionally, cases are much more complex than they were years ago, with comorbidities experience going on, resulting in a need for emergency general surgery. There's a large number of hospitals that have engaged us to provide emergency general surgery when the medical staff, for example, is not interested or unable to cover call any longer. COVID has involved many aspects of healthcare, including the burnout of many specialists and many surgeons, the great resignation, and just dealing with the sicker patients has really caused a lot of burnout. Aging of the physicians. Our surgeon population is aging very rapidly to mimic the rest of the population. We will soon have a shortage of both surgeons and also a shortage of grads in the near future. So further trends that you may be aware of, 2 of 5 active physicians that are in the 65 age group have decided to retire and consider retirement plans. 25% of those accelerated those plans during the pandemic. I'm sure many of you have experienced that at your hospitals. Additionally, resignations. 1 in 5 physicians will likely leave their current practice within 2 years. It's interesting that our model actually speaks to that directly, and provides a vehicle for those surgeons to continue working if they wish. And then lastly, 1/3 would like to reduce their work weeks in the next year. So lots of changes coming very rapidly. So this illustration of what we just spoke about is going to be the shortfall of surgeons. There just are less students entering the field, so we're graduating less. At the same time, our need is growing very rapidly. The aging population, the sicker patients that we're seeing, people waiting to go to the emergency room is definitely a dangerous spiral that is impacting, my guess, your ability to recruit. A bit about Synergy Health Partners. Rich?
Yeah, Synergy Health Partners was founded to address this exact situation. It's a team-based approach where we deploy a team of surgeons to a hospital to provide coverage for them in a variety of settings, whether that's trauma care, orthopedic care, general surgery services. We're #1 in rural health, in particular in the orthopedic surgery line. We're a surgeon-founded company. I'm a surgeon. We have surgeons throughout the organization, and this provides us some expertise in providing care at critical access hospitals, level 3 hospitals, in the rural communities at large. And we've got a long track record now, over a decade, with proven results, both in growing programs, but also advancing them and providing these specialized services to the community.
If I could add to that, this is an illustration of our footprint nationally amongst all our service lines. Thank you.
That's perfect. So thanks, Frank, giving us a little bit of background on sort of what's driving things demographically out there in the population, how things are moving, both in terms of our aging population, but also what we're seeing in my peer group, orthopedic surgeons and general surgeons, my colleagues. But what I want to talk about is, how is this model situated? How did it evolve? And what our role can be in rural health? And so, like a lot of inventions or innovations, there was an obvious problem out there. On the hospital side, hospitals need 24-hour coverage to support their local communities and the patients that are in the communities with various pathologies. On the flip side, surgeons started to dislike call. And so their desire for a variety of stressors was to avoid the call burden. It became complicated in terms of the inefficiencies, meaning you'd have a surgeon seeing a busy office practice and he'd get a call from the emergency room. Now the surgeon's required to be in 2 places at once. Obviously that creates what we call the stress of care conflict, because the surgeon's goal is they want to provide a very high level of consistent care, and you need to do that to the patient in front of you. But it's very difficult to do that if you're being pulled in multiple directions at once. So the founders of this company, a couple of orthopedic surgeons, Dr. Rand Schlusner and John Campbell, wanted to find a solution to this problem. And they devised a model where a group of surgeons can form a clinical team so that they are no longer on the site full-time, 365 days a year. But you could deploy a team of surgeons. So if you had an area where it's a challenge to recruit, you could bring surgeons in from the outside who could cover the trauma, the acute care, the elective care, serve the needs of the community. And unlike a temporary locums role where they're spot filling, this was designed to be a long-term solution for facilities. So the surgeons would be the same surgeons coming consistently over a period of time. And we've had great success with that. Some of our surgeons have been going to the same facility for now 7 to 10 years. And so they get to know the staff, the referring physicians, the emergency room physicians, They engage with the community at large. They participate in community activities, and they become a real true team member for the local hospital.
If I might add, not meaning to interrupt,
Please.
as someone who's been on the other side recruiting surgeons for years, often the challenge is not recruiting the surgeon, recruiting the spouse and the family. And a major aspect of our paradigm is that that's no longer needed. Giving a much bigger net of candidates, high quality nets for you to choose from. Thank you.
Yeah, and so you can see from the slide here, one of our models is a community model. And this is one where we partner, for example, in a community that already has surgeons, but those surgeons are running their busy elective practice and they need help with the on-call coverage. And so that's a role synergy surgeons can play. We've also partnered with private practice groups where the partners no longer have to take call because the synergy docs are doing that. We've done that with hospitals as well as with physician networks. And we've really created a system where orthopedics, for example, can become a true center of excellence in the local community. So how it works, Synergy partners with the local community to develop a model that we then, based on the local facility's needs, we have a variety of advanced techniques we use to recruit a very specialized force to meet those needs. And again, they can be trauma, acute, or elective. And then we continue on with them because it's a long-term relationship to grow and develop the program over time. So it's it's a different model where you have a team of surgeons providing the role. And again, it allows you to bring a real high level of expertise out to the local community. So again, just to kind of sum that up, surgicalists are dedicated, they're on staff, they are part of the local hospital and facility. It's a team-based approach where each surgeon is there for a consistent period of time. That can be 7 to 10 days typically. They are part of the medical staff, they're active on committees. They provide engagement with the community, but they're truly dedicated and focused on patient care when they're there. These are docs who are passionate about what they do, and this is an opportunity to let them continue in that role because when they're away, they have dedicated time off. So it really restores a work-life balance for the surgeons as well. So just to kind of sum up who these surgeons are, they're skilled. The average age of our surgeons is in the low 50s, so they've been in practice for a considerable amount of time. It can bring a lot of expertise to the community, both in terms of their surgical skill set, but also in terms of managing and running an orthopedic practice. They've done it for a couple of decades, so they're looking to reduce their own administrative hassles and not necessarily enthralled with the employed model. But still, they've got a craft. They're passionate about patient care. They love doing surgery, but they want a more predictable schedule and at a point where they want a more flexible lifestyle. It also gives them the option of living anywhere and traveling out to a community to provide these services. And again, it's a little bit of a different model where it's a team-based approach.
But this seems like a good spot maybe to ask you a few questions, if I might. Among those, I'm sure everyone's wondering, as an orthopedic surgeon, why is this good for the doctor?
Gosh, it's a great question, and something actually that brought me to the company because I'm kind of passionate about it and improving the life for the surgeon. Number one, it can extend careers. So those docs that you talked about who are burning out because they've been working 80 hours a week for decades, this is a chance for them to, like I said, still practice their craft. They can bring a high level of skill and they can deliver it in a community that desperately needs it. So it, like I said, then also gives them dedicated time off so they can focus on their family and things outside of medicine a little bit too. So it really has great appeal to surgeons, and I've been consistently impressed by the quality of the surgeons we've been able to recruit.
Thanks. Another question I might have as a prior administrator is this like a locums company? Is this stable engagement? Maybe you could speak a little bit about that.
Yeah, it is not like a locums company. Again, we really view ourselves as long-term partners with the hospital and the community. So our goal is to partner with the facility, hospital, physician group to be in the community for a consistent period of time. And again, it's not like you have Dr. A, you have typically 3 doctors are deployed to a facility, but it's the same 3 and they are there consistently over time. And like, as I said earlier, they become part of the medical staff. They know the emergency room physicians, they know the OR staff, they partner with them to establish protocols and pathways in the hospital. So it really is a long-term solution, and in that way, it's a little bit different than locums for sure.
Well, it sounds very exciting to me. I'm curious, how's the market been receiving it? Is there much interest in it?
Yeah, it's been a timely solution to a problem that has existed for a little while, but has become much more acute because, as you mentioned, Frank, a lot of surgeons are leaving the market, and so it's become tougher to find a quality surgeon to serve the community. So we've been able to go into areas that haven't had, for example, again, orthopedic surgery services for years and establish robust programs, and allows the facility to deliver a high level of quality care and a service line that the community desperately needs. Patients get care close to home, and everyone likes that.
Perfect. Could you speak a little bit about alignment with the hospitals that are engaged, as well as the surgeons in the community, and how that might work?
Yeah, it's a great question, because the potential is always there. You're going to conflict with surgeons in the community. All doctors are a little bit possessive about their patient base, and sometimes they can be worried about, who are these guys coming in and what are they doing? But it's really a complementary relationship. We relieve them of the burden of call, and so very often it's very positive outcome for the local surgeons. And the same side, though, we're very much aligned. If a hospital is bringing us in, well, then we're keeping those procedures, patients in the hospital and in the hospital system. So we're very much aligned with local community hospitals and rural hospitals in particular in delivering care at their facility. So there's no conflict in moving patients from one place to another.
Thank you very much. I'm wondering about case studies, research that you have. What can you put forward to prove our theory?
It's funny, Frank, I had a sneaking suspicion you might ask that. Yeah, I'm going to use a very typical example of a hospital that came to us. This is a rural critical access hospital, lacking orthopedic surgery services. But again, you can substitute general surgery or any of our other service lines. And they really wanted to be able to deliver orthopedic care in their community. They're seeing the patients come into their emergency room, but then those patients are all having to be transferred outside the system because they couldn't provide this level of care. So one of our rural hospitals, that's the problem they brought to us. They wanted to establish an orthopedic program and provide access to orthopedic care in their community. And so this is sort of our model. We sit down with the hospital, we find out what is it that they're trying to address. And so in this particular case, they wanted the full spectrum of orthopedic services, 24-hour coverage, 7 days a week, 365 days a year. They wanted coverage for the emergency room, but elective procedures as well. They want to serve the sports medicine needs of the community, follow-on care for the surgical patients, post-operative care, but also be able to provide those acute fracture services. So we were able to meet those needs, developed an orthopedic program. So we designed it from the ground up We deploy a team of surgeons. In this case, it's 3 full-time surgeons, each serving 10 days a week. We work with the facility on vendor contracting, supply chain, the whole spectrum of surgical care, and we're able to establish a newfound orthopedic program at this facility. We've now been with them 5 years. We have 3 full-time surgeons. Those are the ones that are serving 10 days a month every month. We have a couple of backup providers should the surgeon's schedule conflict or they all want the same days off. We can still cover. There's no gaps in the schedule. We've grown the volume about 40% over that time. And we develop or deploy high quality surgeons, patient satisfaction scores consistently above 90%. Again, this is what we do, and this is our impact on rural hospitals, whereby patients, surgeons, hospital, all are aligned, delivering care in the community. It's quality, it improves facility volume, develops programs, you have high patient satisfactions, and again, 24/7 coverage to a community that otherwise might struggle to provide this level of service. So Frank, I'm gonna give it back to you here.
Well, thanks very much. So this program is very exciting to me personally. As someone who's been in healthcare on both sides of it for 40 years, the ability to give quality care close to home has never been more important. There are over 600 hospitals at risk of declining financial results currently. One of the best ways to address that is by increasing volume, increasing cake sticks, and reducing cost. So some of the takeaways that we have seen from our programs nationwide are, first off, predictable care. That's excellent for the emergency physician, who, if they don't know who to refer to, is likely going to transfer that patient. And once that pattern starts, it's very hard to undo it. For the patient themselves, the ability to get care at home and not have to be transferred. The byproduct of that is increased elective cases. They're there, they're available, there's a halo effect. Even if we're doing ortho, there's a halo effect for your surgeons. And of course, there's downstream revenue. Every one of these cases produces positive financial results for all of our client hospitals, many of which may be reimbursed for cost. Again, for the ER doctor, and that's really my prior role as the emergency room, when that patient comes in and it's an orthopedic case and I don't happen to have an orthopod available to send them to, our next move is going to be to transfer that patient. There's no reason to keep them, so they'll be moved as quick as possible. And we work to eliminate that. We want to keep everyone that is appropriate to be retained in our communities. Of course, support for the community surgeons. We work in partnership. This is not a competition. We do not come in any market that we've not been jointly invited, both by the hospital and by the local surgeons. We are there to complement. And it puts the rural hospital center on a path to delivering higher care. I mentioned that earlier. As you know, the formula is pretty short for financial success for hospitals these days. It's increasing case mix, increasing volume, and decreasing cost. Thank you.
We do value your partnership and what you do for the rural healthcare community so much. So I appreciate your time today.
Great. Thank you, everyone.